All right, can I call the next two speakers up to the podium, Dr. Bouley and Dr. Prada? Um, why don't you come up here? Yeah. I mean, you're going to be talking. All right, so we have sort of a combination, our next session, two different speakers, both on very interesting topics. The first speaker will be Dr. Stephanie Bouley, who is a research fellow at Massachusetts General Hospital, and she has a PhD in experimental and molecular medicine from Dartmouth. Her research is focused on identifying novel therapies to treat NF1, and she's a recipient of the Dorothy and Spiro Lotz's Fellowship in Neurofibromatosis Research from Boston Children's Hospital, and a former CTF Young investigator, and she's going to be talking about sleep disturbances. Our second speaker I'll introduce now is Dr. Carlos Prada, and it's a special pleasure for me to introduce Dr. Prada because we stole him recently from Cincinnati Children's Hospital. Dr. Prada is an associate professor of pediatrics at the Feinberg School of Medicine, Northwestern University. And as I said, he recently joined Lurie Children's, my hospital, and he's a division head of genetics, birth defects, and metabolism. For 6 years, he led the RASopathies program, of which NF1 is one, at Cincinnati Children's Hospital, and where he developed a care-based model on genetic pathways. He has conducted numerous randomized clinical trials of lysosomal storage disorders, NF1, RASopathies, and others. And he's a principal investigator for a large effort to develop novel biomarkers. I mean, he'll explain what biomarkers are to those of you who don't know, of tumor progression in NF1. We'll start with Dr. Bouley. Thank you so much.
Oh, perfect. So hi, everyone. Thank you so much for being here. Like he said, I'm Stephanie Bouley, and I am fortunate to be in the lab of Dr. James Walker at Massachusetts General Hospital. And today I'm going to be talking to you about a couple studies that we are doing trying to find a link between sleep and quality of life in NF1 patients. And so just to give you a brief overview of what I'm going to talk about, I know most of you already know what neurofibromatosis type 1 or NF1 is, but I'm going to just do one slide on it. And then I'm going to talk to you a little bit about what is sleep, how we define sleep based on what type of research you're doing. And then I'm going to talk to you about two studies that we are actively recruiting for at Mass General that are remote. They are, you can sign up today if you so choose. The NF1 sleep study and the NF1 sleep health survey, which was just IRB approved 5 minutes ago. So I'm very excited. And then I'm going to actually share some preliminary findings we have from our NF1 sleep study. And finally, I'll tell you how you can get involved in these studies. And so most of you all know this already, but for anyone who is new to NF research, neurofibromatosis type 1 or NF1 is a tumor predisposing condition that affects 1 in every 35 individuals born. And I started working on NF1 in 2014. I found out about it while I was in grad school, and I was drawn to it. My specialty is actually in drug discovery, and I was drawn to it because of the few treatment options that were available. And since I've been working in the NF field, I have found a number of people that have said to me, oh, my daughter has NF1. I have a cousin with NF1. And so even though it's considered to be a rare disease by statistic standards, you know, it is really a huge community, and it affects a number of people. And I'm sure you know that better. You don't need me to tell you that. And with NF1, we've talked about a lot of different symptoms that are associated with it if you were at any of the talks this morning. But one of the symptoms that I want to highlight is that 50 to 70% of children with NF1 are found to have some sort of cognitive dysfunction. That can be things such as ADHD, it can be on the autism spectrum, things like that. And so I want you to keep that in mind as we talk about sleep and quality of life. And speaking of sleep, I wanted to point out that as far as we know, there have been no objective sleep studies performed to understand how sleep and NF1 relate. There have been a number of subjective, and when I say subjective, I mean survey-based, which has been great to help identify these patterns that we're seeing. But what I'm going to be talking about today is something that is more objective. And actually, if you can see my watch, this is what we're using for our study. And so, as I mentioned, there is a cognitive phenotype that is associated with NF1. And if you think about how you feel on a good night's sleep versus a poor night's sleep, you can probably understand how sleep can impact these quality of life issues associated with NF1. And so, some common cognitive issues that are seen are short-term memory deficit, problems with abstract conceptualization, attention deficit, and a slower processing of information. And so on a good day, you might be able to compensate for these things, but on a poor sleep day, it might be a lot harder. There's also an impact of chronic pain on quality of life, things such as cognitive abilities, addition, subtraction, trying to quickly process things. There's memory impairment that's also impacted by pain. And then there's an emotional component associated with it, such as anxiety, depression, things like that. And so really what we're trying to do is take these symptoms that are associated with NF1 and then determine how sleep impacts them. And so what is sleep? We all sleep, hopefully. I hope no one here is not sleeping. But the standard definition of sleep is a body-mind state where we experience sensory detachment from our surroundings. And that is a very scientific statement. But when you consider, when you're talking to someone who specializes in sleep or research sleeps, there are defining characteristics associated with how we talk about sleep, such as duration, the quality of your sleep, the timing, how long it takes you to fall asleep, how long it takes you to wake up from sleep. But if you're talking to someone who specializes in electrophysiological standpoints, they're going to talk a little bit more about the scientific specifics, such as NREM or REM, which is rapid eye movement or non-rapid eye movement. And these periods of sleep are really important for a host of things, such as bone development, sort of the resetting of your biological clock while you're sleeping, being able to process short-term to long-term memories. And so we really want to understand this aspect of sleep as well. And then when you think sort of about the behavioral criteria associated with sleep, we're talking about no voluntary movement, but something that is reversible, not a coma. We're also talking about being responsive to stimuli. So there's a reduced responsiveness. If I wave my hand in front of you while you're sleeping, you're probably not going to respond right away unless I make a loud noise. And then there are ways in which our sleep can be modulated by things such as caffeine or using electronics has been shown to alter sleep depending on how late you're using them. And so these are all things that we want to take into account when we consider sleep. And you've probably heard the term, your natural sleep cycle, but that really ties into what we refer to as circadian rhythm. So humans are monophasic sleepers, meaning that ideally you only have one period in which you sleep in a 24-hour period. And if you look at this chart here, this is sort of broken into night and day or light and dark. And you can see, depending on what the timing is, how your body responds to different things. So, for example, melatonin generally starts being secreted at 9 p.m., which is great when you are getting ready for bed. And then the melatonin secretion stops at around 7:30 a.m. And so if you're able to go to bed right around when your melatonin secretion starts, you might get a really good night's sleep. But what about people who sleep less or sleep more? You can see if you're waking up or going to bed later, it can impact different things. And so a number of studies have been done on sleep and NF1, but they have been, like I mentioned, survey-based. As you can see here, looking at depression, looking at sleep disturbance, work experiences. And all of these studies, while they are subjective, they are important because they've laid the groundwork for us to identify that patients have been saying there is a problem with their sleep. And it's been reported through all of these surveys that sleep disturbance and poor sleep quality is significantly more frequent in adult NF1 patients, and that it's most likely due to a number of factors. So this includes pain, anxiety, depression, cognitive issues, and their organic sleep pattern or their circadian rhythm. Now, as I mentioned, I am in Dr. Jim Walker's lab, and he actually specializes in the fruit fly. So we actually use Drosophila to study sleep in the lab. There are other labs who use mice, and so I'm just going to show you a little bit of what we've seen in animal models that supports this idea that there is a need to study sleep in NF1 patients. So we use a system that's called a trikinetic system. And what it does is you put a fly in a tube, and you put all these tubes in a little cassette, and then you put all these cassettes in a big machine, and the machine has a laser that runs through the center of all the tubes, and it will measure how active the fly is during the day and the night. And so this is what a control fly looks like. If you can see the white and the darker shades of the graph, the dark is representative of when the lights are off, and so that mimics their nighttime, and the light part is supposed to be during the day. And flies tend to be most active at dawn and dusk. And so you see those peaks that are in black, that's indicative of fly movement. So this is what a control looks like. Now, this is what an NF1 deficient fly looks like. They have almost no regulation of their sleep and wake cycles. They have severe sleep fragmentation. They're active throughout the night and the day, and it kind of just looks like a very busy cityscape. Now, in mice, we can do a little bit more in-depth studies because they are mammals. We're actually able to do a little bit more. We are able to recapitulate the sleep fragmentation that we see in mice. So if you see those white bars, those are NF1 deficient mice, and they have increased sleep fragmentation. But for mice, you're actually able to also do EEGs. So if you've ever seen one of those helmets that has the electrodes coming out of it, perhaps you've been watching Stranger Things recently and you've seen Eleven wearing one. It's very similar to that, but it's on a mouse. And they're actually able to see that there's an increase in what's called delta power NREM sleep. Now, I am not a NREM sleep expert, but from what I understand from reading the research, this can indicate poor cognitive function, and it can indicate poor sleep quality. So at Mass General, we've put together a team of experts in sleep, NF1, and cognitive studies to try and identify what the relationship is between NF1 and sleep in patients. And so this is our team here. And I'm going to talk to you about 2 studies and tell you how you can be a part of the team. I'm going to share our website where you can go and find out more information. So I just want to point out now that we have 2 buttons on our main page. One is for the NF1 sleep study, which involves the watches. One is for our sleep health survey study, which is just questionnaires. And if you click on either of those buttons, they will bring you to the relevant information. And I'm going to use these to help distinguish the 2 studies. So for our NF1 sleep study, we are currently still in the recruitment phase. This study was funded by CDMRP right around when the COVID lockdown was being lifted. And so we have been actively recruiting patients, but it is a little bit of a slow going process. However, we've been doing this through the NF clinic at MGH, through a number of NF foundations, and also our website. And the majority of the recruitment has been done by a former lab member, Angela Chen, and Anika Fernandez, who's actually out at the table right now, right outside those doors. And so our goal is to get 100 NF1 patients and 100 age and sex matched controls that do not have NF1. And what we're going to be measuring are 4 things. We're going to be doing biobanking through a saliva sample. We're going to be gathering actograms using this lovely watch. We're doing daily sleep diaries for participants to rate how they feel they slept. And then we're also doing cognitive surveys to see the impact of sleep quality on cognitive response. And all of this, we are hoping, will help us define sleep-wake behaviors in individuals with NF1. And so this is sort of what it looks like. Since my wrist is pretty small, here is a larger picture of the watch that we are using. The saliva sample that we're taking is to measure markers of sleep that can be detected in saliva. And this is something that you only have to do one time. And if you do consent in person, you can do it there. Or if you are doing this remote, because you can do this from anywhere, we will send you a kit, and it has a little tube with a little swab, and everyone I think is really good at swabbing now. So you just do it in your mouth, not your nose, send it back. Like I said, we're also gonna have a daily sleep diary, and then we have cognitive surveys that you fill out. It's estimated it takes about 10 minutes a day for 2 weeks. And this is sort of what it looks like. So you would come and do a virtual consent visit, or we are aiming to sign up some participants this weekend. We do have 6 watches with us that we are able to consent patients, and they can actually leave with them. But basically, you sign a consent form, we do a saliva sample, you fill out 15 to 20 minutes of questionnaires, different information about how you feel you sleep, your NF1 status, things like that. And then you start wearing the watch for 2 weeks. It is waterproof. You can go in the shower, you can go in the pool. You do not have to take it off at all. I slept with mine last night to see how comfortable it is, didn't notice it, and I am not the best sleeper, so that was exciting for me. We do our daily sleep logs, and then you have the online cognitive assessments. Like I said, it's about 5 minutes once a day, plus the 5 minutes of the sleep diary, so you're looking at about 10 minutes a day. And so here's the information most people really want to know: who can participate in this study. Right now, this is for adults 18 and older, with or without NF1. Like I said, we're looking for age-matched and sex-matched controls. So if you have a friend or a family member who's the same gender as you, they could potentially sign up at the same time as you, and they could be your age match control. If you don't, no worries. We have a group of controls that we can pull from to find someone who will match you. Who can't participate? Adults that have diagnosed sleep apnea, and not something that you think you have, but you have actually been diagnosed by a physician, are not able to participate, as are adults who regularly work night shifts, because your circadian rhythm is off. And so you will definitely show up as an anomaly on this study. Now, what are the benefits? You get $50 in compensation. You get a free personalized sleep report, because these watches will tell us how often you're waking during the night, what your sleep quality is like, things like that. There's no cost to participate. It is no travel is required. It's home-based, and there is no change to your current medical care. So this is not going to alter anything that you are doing right now. Now I'm going to briefly mention our NF1 sleep health survey, which, like I said, was just approved. The goal of this is to understand the relationship between NF1 and quality of life outcomes related to sleep. It is entirely survey-based, so this is a one-time 20-minute series of questionnaires that you fill out, and that's it. The surveys range from sleep-related situations like how sleepy do you feel during the day? Do you feel like you have sleep disturbances? Are you a morning person or a night person? Do you have insomnia? How much sleep do you think you're actually getting versus when you go to bed and when you wake up? Is there pain interference? Is there any functional associated outcome that you feel like you have impairment because of how you're sleeping, things like that. And so, like I said, this was just approved. I am in contact with the team back home to try and actually get the surveys on the website as soon as possible. So if you do visit our website and you still see that it says, check back here for more information, hopefully I'll be able to get it up and running within the next day. If not, like I said, keep checking back if you're interested in participating. And so now I'm going to show you some preliminary results. So we currently have 27 patients who have been enrolled and 8 controls. The average age is about 45, with 22% being male. Most of our participants so far have been female, but we still have a number of participants we need to get. And as you can see, about 1/3 of our patients are from Mass General, so 2/3 have been gathered remotely. And so here we have a graph showing our controls and our NF1 patients and how many times they're waking up during the night. And what we found on average right now is that NF1 patients experience more awakenings in the middle of their sleep cycle throughout the course of their study. And so this is the average over 14 days. We've also begun looking at pain, and we see, at least in one patient, that there is an association between increased sleep duration, so how long you are sleeping, and lower levels of pain. So if you sleep more, you have less pain that day. If you sleep less, there is more pain. But this, like I said, is preliminary, and so we're hoping to reach our goals for participation, and then we can get some more concrete results. So would you like to participate? You can visit and share our website. It's nfsleep.massgeneral.org. Like I said, when you go onto the main page, we have these 2 buttons that will bring you to the respective page to tell you about the studies. If you click on the NF1 sleep study, it will bring you to where you can actually fill out the red cap. But if you are interested in signing up and you're here, I encourage you to go to our table, because we can get you on the list a little bit faster than going through the red cap that's on here. If you're interested in actually joining as soon as possible, like I said, we do have some watches that we're able to consent and hand out. And then, like I said, the NF1 sleep health surveys will be up and running shortly. And then one of the things that I get asked a lot when I talk about this is, why aren't we doing this in children? Why aren't we doing this in young adults, adolescents? And there's several factors that can play into that. One of the things that we found when we were looking at setting up this study is that there's a lot of cognitive surveys that are have a short age range. And so between ages 9 and 11, there could be 2 completely different sets of cognitive functional tests that are performed. But we are working with Nicole Ulrich. She actually signed on this week to help us develop a sleep study that uses the actigram watches for young adults and adolescents to try and elucidate information at a younger period of time where you're in school and, cognitive activity is very high because you are in school for 6 to 8 hours a day and then homework and all of that. But there have been, again, some surveys that have looked at NF1 and sleep in children and young adults as at a subjective level. And they have found that children are more likely to have disturbances in being able to fall asleep, staying asleep, being able to wake up, and transitioning from that sleep to wake period. There's also a report that they sleep for longer, not due to a coexisting condition or due to any sort of drug use, any sort of medication that they're on. It seems to be associated with NF1. And so we're interested in being able to use the methods that we developed with our objective study with adolescents. And so with that, I just want to acknowledge the two main labs that are a huge part of this, the Saxena lab and the Walker lab. Like I mentioned, Angela and Anika have been doing a lot of our patient recruitment. They go down to the NF clinic and sign people up, consent them, send out the watches, analyze the data, things like that. And then Tori and Nick in the lab that I am a part of have actually been doing all of the fly studies. So I showed you some data on flies and sleep, but we also do cognitive studies on NF1 deficient flies. We do a whole host of different assays. And so they have been sort of doing the pre-clinical studies in these animal models. I also want to acknowledge the NF clinic at Mass General, where we've been recruiting patients, and the patients, participants themselves. I know there's at least one person here who was actually part of this study, because he came by to our table earlier. Oh, okay, cool, yeah. So thank you for being a part of this. Yes, yeah, that's awesome. Yeah, so thank you guys for being here. Like I said, come visit our booth if you want more information. Feel free to reach out to me on the app. And I also want to thank our funding, the CDMRP Department of Defense, because without that, this would not be possible. And this is a picture of my lab. So thank you guys so much.
Thank you very much, Dr. Bouley. Thank you very much, Dr. Bouley. I think we'll hold questions because we're really time limited and see what we have at the end of Dr. Prada's talk.
Perfect.
So, now for something completely different, we'll turn it over to Dr. Prada.
Thank you, Bob. Well, it's fun to be here. There's a lot of faces that I know, even with masks. So my topic is a little different, but I'm very keen to sleep, very important. We spend a third of our lives sleeping, So very curious about the findings of the study, So my talk is about biomarkers in plexiform neurofibromas, and a little bit about our research focus. And for my group at Bouley, we're trying to work on biomarker development, and we have an R61 grant for that purpose. We're also very interested in genetic modifiers, and we actually have some pilot funding to generate some hopefully exciting data for a larger study. We're also doing some genotype, phenotype, which I don't have funding, but I have a med student that has done a wonderful job. And of course, we want to participate more in therapeutics. I was the PI for a Department of Defense grant for motor behavior, which continues at my previous institution at Cincinnati Children's. So NF1, I don't have to talk a lot, we are very familiar that this is a multisystemic disorder that leads to overactivation of this signaling pathway called the RAS pathway. And NF1 is really the first step that controls how active is that pathway. Because it's that first step, a lot of other signaling processes are upregulated, and that's what leads to this predisposition to develop tumors. Plexiform neurofibromas are one of the most frequent type of tumors we see in this patient population. And there are some few actually genotype phenotype correlation. One of them is the microdeletions, which we tend to see with larger number and earlier onset of plexiform neurofibroma, and also risk for malignancy called MPNSTs. There are also a couple of missense variants in certain locations that are also at increased risk for what we call spinal neurofibromas and other types of tumors. Now, why is the peripheral nerve important? So there is, when you have an F1, you're missing the NF1 part of part of your NF1 in your genes. So you have half of the genetic information, but it's still one copy is not working as well. But in the Schwann cells, actually are cells that are present only in your peripheral nerves. They're very important to support the growth of your neurons there. And also there's different types of Schwann cells. One, what we call the myelinating Schwann cells, and the non-myelinated or Rimac bundle. These are very important to just keep your nerves very well organized. Yeah? And when you have NF1, what happens is there's disruption of that normal structure of the nerve, which is gonna lead to influx of other cell types and the unusual growth that can happen on those nerves. And that's what leads to the plexiform neurofibromas. So I was actually chatting with my son last night. It's kind of hard to see here. But he described the Rimac bundles on the right side as the honeycomb. Yeah? And on the NF1 patients, you have the less normal structure of those Rimac bundles, and he said just honey drops, yeah, which I thought was pretty clever. Yeah, he's 10. Yeah, he barely pays attention to me, so thank you, thank you, Karen, for your talk, and I'll be applying that a lot. Yeah. She's great, yeah. So plexiform neurofibroma, so you see, so you have normal structure of the nerve, it's not as well tightly organized, so there's a chance for cells to grow in different ways, yeah? So I wanna say this is very common, yeah? 30 to 50% of the patients with neurofibromatosis can have a plexiform neurofibroma. These are benign tumors. That means that not every patient will develop symptoms. Not every time will lead to a malignant transformation. And they're usually, we think in the field, they're present at birth. They're just not, you cannot feel them or see them, or they're just growing very slow. We are lucky these days that we have lots of researchers through different foundations and different grants that have developed very good animal models for us to understand how this neurofibromas happen. Yeah? So we have lots of different mouse models. This is just one of them. And we know that nerves very soon after, in this case, a mouse model, at around 1 month of life, you start seeing disruption of those nerves with infiltration of cells. And then around 4 to 7 months, you start seeing the neurofibromas growing out of those nerves. So we know it's very early in the animal model, and we suspect it's the same in the human disease because we can see them very early in life as well. Now, they are located any part of your body. Yeah? There's one there in the hand, in the actual tenoid region of the hand. And sometimes you will see changes in the skin texture. You can see increased pigmentation. You can see hair patches. Yeah? And they may feel different. So if somebody is feeling different, that requires an examination by your doctor, and then we can look if it's reassured or not, or it's causing symptoms, but it can happen anywhere. Now, lots of studies have been done, and this is what led to having clinical trials in a medication that we now use for treatment of some of these plexiform neurofibromas. So this is the work of many people, but led by the NCI, Eva Dombey, doing the imaging studies. Yeah? And what we have learned throughout those many studies is that plexiform neurofibromas grow faster in children. Yeah? So children younger than 8 have a more rapid growth of these neurofibromas compared to children older than 8, and even compared to adults. Yeah? So that we know, and that we know that they can grow faster than your body. So that means if we compare weight gain to the growth of the plexiform, we can see differences on those. Yeah? Thanks to that studies, then we have developed ways to assess how we should measure them and how they should respond to therapy or not. Yeah? Now, where this, so we talked they can be located anywhere. So we did a study now a decade ago, looking at patients that have symptomatic plexiform neurofibromas and where were the most common locations for those neurofibromas. So we found that the most common symptomatic locations where plexiform neurofibromas located in the head, face, and neck region, followed by plexiforms located in the extremities. But they can cause symptoms that are quite diverse based on the location. um, or they can be asymptomatic. As I mentioned, many will not lead to symptoms. When should you be concerned? So if we have rapid growth of the plexiform, yeah, if you have constant pain that is not going away, yeah, or if there's a change on how you feel, if the texture is changing, yeah, or if there's new neurological symptoms such as weakness, yeah, um, or if you have difficulty breathing or swallowing, if it's located close to um, regions in your chest and your mediastinum, which is the cavity where a lot of important organs are in your body. Yeah. And they also can have a risk for malignant transformation, about 8 to 12% lifetime. And that's important for us and patients to know that that's a risk that we need to follow. Yeah. Now, how do we check the plexiform neurofibromas? So RAINS, which you guys are very familiar with, is a very important effort to try to provide us with guidance, not only for patients, but for providers about what should be the right imaging, when should we do it, and have some sort of consensus about what we do in clinic. Yeah? And this actually was very important as they were launching studies for clinical trials, how we should see if a patient responds or not to a therapeutics. Yeah? And one is what so when we talk about imaging, so whole body MRI, yeah, is something that is not available at every location. So that's important to know. Two, actually looking at the imaging is not quite, it takes time and measurements are not always taken. Yeah? So that's another limitation that we have. But for natural history studies and for clinical trials, there's the ability to do a lot of different ways to measure those neurofibromas. Yeah? So in that initial study by RAINS, they look at how should we measure one dimension, yeah? So taking the largest dimension of the neurofibroma, or checking 2 dimensions, or versus three dimensions or volumetric assessments. Now, the big difference is over time, if you take more measurements, you're going to be able to see more changes quickly. And that was important because if you are trying to do a clinical trial and you're trying to see if there's a response to a medication, it's going to take you less if you have more detailed measurements to see if a medication is working or not. Yeah. And also, if you're trying to follow this clinically, it will tell you more if the neurofibroma is changing or not in size. Yeah. This doesn't necessarily always correlate with symptoms, but it's a tool that we have these days. Yeah. All right, so now another important study also from RAINS is that how are clinics doing this, and which is also important. They actually probably surveyed mostly centers that do have access to imaging or that they have a significant expertise with neurofibromatosis, and they look at what was the utilization of imaging in patients that were asymptomatic, yeah, versus patients that were, and then they stratified both categories, adults, yeah, versus children, and also patients that have non-plexiform neurofibromas versus patients that did not know have a plexiform neurofibroma. So non-known or visible neurofibromas is in gray, in black, patients that have known plexiform neurofibromas. And as you can see in adults and in children, the most common decision was not to do any imaging, yeah, if you didn't have any symptoms, followed by utilization of whole body MRI. Yeah, so that's becoming now more frequent, but it still is not. There's no consensus, and there's other imaging modalities such as CT, PETs, and others, yeah, that are not as commonly used, but some centers do use. Yeah? Now, the opposite scenario where patients that have symptomatic or symptoms related to anything or a plexiform neurofibroma, and you have adults and children again, and there were a little bit more consensus here. If you actually have symptoms, what we'll recommend is a regional MRI, so an MRI of the location where there is a symptom, yeah, regardless if you had a known plexiform neurofibroma or not. Yeah? And again, this was followed by a whole body MRI. Yeah? but the consensus mostly was about doing that regional MRI. So we say little consensus across many centers, yeah, which is now a sort of challenging scenario. Part of the consensus could be one, familiarity with the scans, who is going to read them, the risk for incidental findings, yeah. But with now having therapies being developed and knowing additional complications of the disorder is something that we should think about how we should offer this type of imaging. Yeah. So more to come on that end, and I'm sure this will continue to evolve, yeah, but will require more access to this type of imaging as well, yeah, and more expertise about what to do with the imaging as well. Now I'm gonna go back now to my research, yeah. So since Bob wants me to define a biomarker, yeah, I probably should start with that. So a biomarker is really a measurement, yeah, something that I can measure that I can correlate in a context. So for example, in this case, we're looking for a marker in blood that correlates with the size of the neurofibromas. Yeah? So that's what we call a context of use of a biomarker. Yeah? And why is that helpful? Because we talk about this little consensus about imaging, there's lack of access of imaging at many centers, yeah? There's lack of expertise to read these MRIs, yeah? And now there's a treatment that potentially can help with some of those symptomatic plexiform neurofibromas, yeah? So there's a lot of need for something like that. But biomarkers are actually really hard to come by. So there's very few biomarkers that are actually approved in medicine, just because it's really hard to correlate a number with symptoms, with disease, and there's also many modifiers of that. So, so that's the reason for us to start with what we call a big unbiased discovery phase. So we work on this for several years, trying to use plasma from either patients or animal models to see if we can find a marker in blood that we could measure that may be relevant to the formation and growth of plexiform neurofibromas. So mass spec is actually a very well-defined technique. It's not new anymore, but it's actually being used more on the medical setting. Yeah? So we actually have some exciting data. This is now several years ago too, yeah, that we found that there's actually different markers in blood when we compare healthy controls versus patients with NF1. And actually we could tell apart a little bit in between patients that have neurofibromas or plexiforms versus the ones that we didn't. Yeah? Now, this is not a clinical test. This is something that we did for discovery. And when we actually align based on the abundance of these markers, we see that the patients with NF1 will cluster together, and the patients that have some sort of neurofibroma-related tumor also came close together, as you can see in that heat map. Yeah. So with that in mind, yeah, so we did, we actually spent lots of time trying to find out where those compounds, yeah, and the limitation was the abundance on blood was very low, and we were not really able to characterize them. We were able to put them on a class of, or a type of molecules. We call those lipids, yeah. So we actually decided to go back to our drawing board and do a more in-depth characterization of lipids, yeah. So there's a whole different way to set up how we extract lipids from plasma, yeah. But instead of doing it in patients, we went back to the animal model because, as I mentioned earlier, we know very well when a mice with an F1 doesn't have neurofibromas, and when they have neurofibromas, and when those neurofibromas are large. Yeah? And then start comparing blood samples from different animals at different stages of their life and see if we actually saw a signal that was different. Yeah. So this was a fun experiment, but we actually did found right around 7 months when the mice have large neurofibromas, we start seeing a signaling in blood that was different, yeah, from the age-matched control mice. Yeah? So it was not very high, but was statistically significant, and we call those glucosylceramide and lactosylceramide species for which is a pathway that we actually have a lot of understanding. Yeah, not to the degree that we see in other genetic disorders, but it was interesting for us that this could be a potential marker that tracks with neurofibroma formation, at least in the animal model. Yeah? And when we actually do MRIs in the animal model, we quantify that volume, and we saw that there were some degree of correlation. This, what you can see on the right side of the slide. Uh, if we have a level that was of 800, that animal likely have a tumor that was over 100 mLs, and if the level was in the 200 range, that mice with NF1 had a smaller tumor. So this is not a perfect correlation, but was good enough for us to say, hey, we should probably pursue this and see if we see a similar pattern in patients with NF1. Yeah. So that was our reasoning to start this biomarker study that we're currently conducting at Louis Children's. And basically what we're doing is 2 time points imaging. So we establish a baseline, we do volumetrics, and then we're gonna repeat that same MRI in a year and see how much in volume the neurofibroma grew. Do we have any growth or not? And see if that biomarker level changed or not over time. Yeah. So our goals is, can this correlate with growth, or can this correlate with the size of the neurofibroma? So that means the larger the neurofibroma is, we're going to have a larger number on the biomarker or not. Yeah. And 3, can we actually use this biomarker to help us guide, is the patient likely to respond to this treatment or not? Yeah. So those are 3 questions we are set to explain over the next 3-5 years. Yeah. So we are hoping to enroll in between 150 to 200 individuals with NF1, yeah, and do what we call a whole body MRI. Now, whole body MRI is not very good for brain, head, and face, but it's really good neck down, yeah. And we actually got IRB approved as well, yeah. We started this past March, yeah, and we have great participation for the community here in Chicago, and we have about 20 patients enrolled in this protocol, yeah, which is about 10% enrollment for us. Yeah, we're getting there, and we are hoping to do this over the next couple of years to validate this biomarker. So that is what we are doing for our study. Yeah, so we're listed in clinical trials. Yeah, if you want to get more information. And Mike, who is there, yeah, he was complaining he didn't got enough traffic, so I gave him a shootout. Yeah, he has really cool pens there. Yeah, Luri has good taste on pens. Yeah. So stop with chat with him. Yeah. Okay, so I'm gonna change gears. So a little bit about genetic modifiers. So actually this actually is really interesting because now we have the technology to look more in depth your genetic information. So not only your NF1 variant, and this is actually a study that was done by my research mentor, Nancy Ratner, where she looked at exons from individuals with NF1 and see if there were any other variants in other genes that could explain why some patients have more neurofibromas than others. Yeah. So this study was recently published about variants on a gene called ATM, and then she tested these variants in the animal model and did show that the variant, if a patient with NF1 had a variant on ATM, had a higher chance to have larger neurofibromas and more numbers of neurofibromas. Now, this was only validated in the animal model. Yeah, it needs larger numbers of patients to really validate if this is a true modifier of NF1. We actually just conducted a study in collaboration with her, and we're analyzing our data. So more to come on that end. But this is something that we can now start looking more and learn more and try to anticipate risk for patients. Yeah. Now, this is the study that my student was doing this summer. She's next to Mike. You can say hi. Yeah. She actually did a great job. So her question, or part of the research question, was, are patients with microdeletions and NF1, what do we know about eye-related complications? And also look at how our patients at our center are doing developmentally. Yeah. So this was a retrospective study. We identified 12 patients out of our population at Lurie. It was actually not an increased risk of ophthalmological complications. So we have lesion nodules, which are very common. One patient have an optic pathway glioma, yeah, which is a similar incidence that what we see in NF1, not related to microdeletion. And we have many patients that are very young, they are going to school, they're actually achieving a lot. And we have 2 patients that are adults that have graduated from college university, which is also very good to expand what we currently know about microdeletions. Yeah. So more to come, hopefully this will get submitted. Yeah. She will be leaving us soon. And finally, I want to thank you, my division, Bob, who was a great recruiter, continues to be an excellent recruiter. Yeah. I'm very happy to be here. So the team is large and we're trying to grow and do more for NF. Yeah. Thank you.
Thank you, Dr. Thank you, Dr. Prada. Okay, now it's on. Thanks so much. Now, we have 10 minutes. There are a number of questions in HUVA, but a lot of them are about sleep. I'm not sure Dr. Bouley wants to answer sleep questions, so I'm going to start with the more generic questions first. And anybody in the audience, if you have questions, I think it'd be helpful related to the studies. That would be a good starting point. So first, I guess for both of you, can people in Canada or in Europe participate in either of your studies? What, Dr. Bouley?
Yeah, so in our NF1 sleep study that uses the watches, I checked with our coordinator when I saw the question come up, and it is based in the US only because we have to ship the watches back and forth, and you know, the plugs and things like that. But our sleep health survey, I think, is open to Canada and Europe. I am not 100% sure. I do need to check, but because it is online and because we purposefully designed it so that it is in the same languages that the NF registry is made available to, I think that it can be expanded.
And maybe you can answer them on HUVA once you find that out.
Yeah,
Great.
I can for sure.
Dr. Prada, do you have any, can our studies be, well, there's a corollary. Where was it? Where did it go? Do you have to live in Chicago to participate in the biomarker study? Our 4-year-old has a recently presenting plexiform and will be scanned later this year. So he is at the beginning of his plexiform neurofibroma path.
Yeah, that's a good question. We are trying to do children that can do the scan without sedation for our local study, but if somebody is having a clinical MRI, we'll do our best to coordinate with the clinical MRI for sedation, especially in young children. It's an NIH funded, so I try to facilitate anybody that wants to be enrolled. It just is going to be challenging is transferring the sample, yep, from where the MRI will be done. But if it's a major center, maybe we can talk offline and see how we could potentially do it, yeah. We have talked to a couple of collaborators. It's just challenging processing the sample in the right time. Once we have it validated, yeah, we can, it will be less labor intensive, but we're happy to chat. If you want to give us your information later on with Mike, we can coordinate it.
Other questions about the studies themselves? I'm trying to be fair to Dr. Bouley, who is not really a clinical sleep medicine expert, despite the sleep questions. I will answer one. Is there a connection between NF1 and sleep apnea? I think if you have a neurofibroma or a plexiform neurofibroma in your nasopharynx or in your chest, that can certainly affect sleep apnea and your breathing. In fact, that's a biomarker we are using for the selumetinib, for any selumetinib study related to airway compression and the growth or shrinkage of a plexiform neurofibroma. But I think kids with NF1 could have tonsils and adenoids just like kids who don't have NF1. Are there any other study-related questions? And if not, we can end this a few minutes early. Okay. I call this session adjourned. Thank you. Thanks very much. I haven't called the restaurant yet.